PBL for this one?
It was very good. It was a nice seamless transition from endorepro to MID.
Oh, nice. طيب this session إن شاء الله will be the PBL wrap-up session. طبعا لأنه it's a new block, they like to experiment new things. The aim of this session is basically to see if all group have achieved the learning objectives, to highlight or to shed light with important things that will show up in your exam, and to answer your questions as well. فدكتور Khaya? So Khaya teaches you.
She didn't come.
She only told us like last week.
Oh, okay. So she'll be here today, inshallah, with Dr. Sabri to address any questions that you have regarding this. Yeah? So they come. So this is, remember the outline. We'll do first the case review and objectives, and then we'll discuss the routine of gaining care, hypertensive disorders and pregnancy, preeclampsia, we'll discuss approach to management and clinical approach to congenital anomalies, neonatal screening and pre-emergency screening, and clinical approach to postpartum depression. طبعا supposedly we're going to cover these objectives, but we'll briefly touch upon them. If there's no time, I'll take the presentation. Come on. Please, can anyone present the case?
I can just we can just recollect what happened. So a woman, so she was pregnant, I think, and they've done. Wait, guys, let me land. Let me land. Okay, so a patient, she came, she's pregnant. Okay, and then you've done the first antenatal visit. We discussed what visits should be done in general in the first part of the case. In the second part of the case, they did an ultrasound. Then they observed there may be some abnormalities. The nuchal translucency was a bit higher, and then they were just counseling the patient and telling them what possible trisomies she can have. According to my group, we discussed like the different types of trisomies, the prognosis and severity. Trisomy 21, 18, and 13. Trisomy 21 is Down syndrome, as you all know. Trisomy 18 and 13, there are more severe cases, and even to the point, trisomy 13 has the worst prognosis, even like a year, which is more severe. It has more severe effects, like deformed ear, so on. My TA went through multiple scenarios, and he also showed us some pages from first aid regarding the changes we can receive. And we just discussed, what counseling can be done in general.
Thank you so much. Great. So, Doctor, would you like to start with the part first? Yes.
What?
So we start about the screening and diagnosis.
It will be the same. It's the same as previous one.
Yes, the same discussion.
Okay. Oh, I mean you can proceed.
Okay, so proceed first with the observation. So as you mentioned, we had the patient, she came late for her first booking visit. She had advanced maternal age, underwent IVF. Her pregnancy was achieved through IVF and she was overweight. Later, she presented with headache and her blood pressure was with 156/62 and proteinuria. Accordingly, we diagnosed her with preeclampsia without severe features and she was managed with oral antihypertensive. Later, she presented again at 35 weeks. Her blood pressure was 176 and over 102. And she had blurry vision. Her liver function was deranged along with low platelets. So she was admitted to the labor and delivery ward as a diagnosis of preeclampsia with severe features, and she underwent C-section. After her baby was admitted to the NICU for 2 weeks, and unfortunately the baby died. Later, 6 weeks postpartum, she presented with loss of interest, irritability, sleep and appetite changes, and suicidal ideation, and we diagnosed her with postpartum depression. Thank you. Just recap, what's the routine prenatal care?
Starts at less than 10 weeks.
Excellent.
It involves multiple stuff, like ultrasound to check for everything.
HIV testing, excellent. STIs. CBC.
GBS.
GBS, excellent. When do you do GBS?
Third trimester.
Third trimester. What else?
Blood group typing.
Excellent. Blood type.
RH positivity or negativity.
Excellent. The antibiotics.
Anomaly testing, 18 to 24 weeks.
Bravo. So you mentioned most of the investigations, as we mentioned in the CDC, ABO blood type, STI screening, ruminant varicella immunoglobulins, urinalysis, and urine culture. Why do we do urine culture? Excellent. Like, if we have a patient, her urine culture came out positive for GDS, what would be the appropriate one? So you treat, excellent. You treat with antibiotics. What else after treatment?
You do periodic culture.
Excellent. So you repeated culture to ensure cure. What else?
Make sure the child does not have neonatal meningitis.
How do we make sure? Is there anything that would be given to her intrapartum?
Intrapartum, yes. Antibiotics.
Which are?
Penicillin G.
Excellent. Yes. So antibiotic therapy for treatment of bacteriuria, and then you repeat culture, and she requires intrapartum GDS prophylaxis with varicella. This is the must, regardless of the GDS culture at the third trimester. GDS bacteriuria is an indication for intrapartum prophylaxis. Vaccine only if she's due, and targeted testing like hemoglobin, electrophoresis, and TSH can be done depending on the case. So would you screen for type 2 diabetes in the first prenatal visit?
Screen, yes.
We wouldn't want to make sure, yeah.
For every woman?
We want to make sure if she has gestational diabetes or not.
Excellent. But when do we usually screen for type 2 diabetes? Timeline.
You screen in 24 to 23.
Excellent. So we screen typically 24 to 28 weeks. Early screening, which is in the first prenatal visit in the first trimester, only for high-risk women. What women we consider in her high risk?
Over the age
Obese, excellent.
35.
And
Over the age of 35.
Previous history.
over age of 35, excellent.
Previous history of hyperglycemia.
So in high risk, GDM in a previous pregnancy, the gestational diabetes, it's an indication by itself for early screening, obesity, a BMI of 25, plus one or more people. Okay, so obesity alone is not an indication. It has to be accompanied either with a first degree relative diabetes, a previous macrosomic infant, age above 35, and history of cardiovascular disease, hypertension, high risk ethnicity, or PCOS. Second trimester, we said we screen for what?
Structure abnormalities.
The hepatitis initially, first visit.
Diabetes.
Diabetes.
First year.
So GDM screening would be 24 to 28 weeks. The screening test would be
OGTC.
50 glucose challenge test. How do we confirm the diagnosis?
If the random blood glucose is still elevated, that's the one.
Excellent. This is a screening test, and 50
Right.
glucose is a screening. Is there a diagnostic test?
Oral glucose tolerance.
It's both of them are glucose tolerance tests, but
2 hour test?
3
Yeah.
That's excellent. So it would be 100 gram glucose tolerance test at 3 hours. The first one is only at 1 hour. Now in third trimester, we repeat CBC, repeat STI, and GBS, rectovaginal culture. How do we classify the hypertensive disorders?
So we have first chronic hypertension, and this is hypertension that also was prior to pregnancy. And then we have gestational hypertension. So this is hypertension that's onset, I believe, after 20 weeks of pregnancy. And then we have some of the more other hypertensive emergencies, such as preeclampsia, which is gestational hypertension with evidence of proteinuria and or end organ damage. Then we have eclampsia, which is just with the addition of seizures. And then we have HELLP syndrome.
Inshallah, I covered it all. So as you mentioned, in less than 20 weeks, chronic hypertension can be white coat hypertension, but it's not a true hypertension. After 20 weeks can be gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome. HELLP syndrome, do you know what this stands for? Excellent. And weight liver enzymes and no pain. So the diagnostic criteria to be new onset hypertension should be measured in 2 separate occasions, at least 4 hours apart, and either proteinuria or evidence of end-organ damage. What are severe features of preeclampsia?
Any signs of end-organ failure?
Excellent. So like excellent. So kidney failure, elevated creatinine, deranged liver enzymes, pulmonary edema, very important one, headache, blurry vision, and high range of blood pressure.
Help? Help as well?
Health is considered, yes, which will be elevated liver enzymes and lignins, but usually it's on the severe spectrum. Some people, they consider health as a sedative. It's not a part of the hypertensive disorders because in 20% of the cases, it's not associated with hypertension. So it will present only as elevated liver enzymes and lignins with hemolysis and no hypertension in 20%. طيب. So we have this woman, 28 weeks of gestation. She presents with headache and blurry vision. Examination, blood pressure is 150/87. Repeat measurement of blood pressure at 4 hours shows the blood pressure is 152/87, and urine dipstick shows 1+ proteinuria. What's your next step in the diagnosis? The most appropriate next step for the diagnosis?
خلاص, it's a diagnosis of preeclampsia, but maybe we can give them magnesium. Urine analysis. Because it's 1+ protein.
Yes?
Repeat your analysis.
So 1+ proteinuria, and not only it's a urine dipstick by itself does not confirm the diagnosis of proteinuria. So we need to do what? Either protein to creatinine ratio or 24-hour urine collection for the total protein. This is very important. Okay? So protein to creatinine ratio 0.3 or 24-hour of above 300 confirms the diagnosis of proteinuria. طيب, now for this patient, she is a woman at 23 weeks of gestation, presents with new onset hypertension and proteinuria. Diagnosis of preeclampsia was made, and she's clinically stable with no severe feature. What's the appropriate management?
Deliver her after 37. Antihypertensive.
Excellent. Yes.
Conservative.
Antihypertensive.
Antihypertensive, excellent. We can consider oral antihypertensive.
Methyldopa, labetalol, nifedipine, and phenyl. The fees, but we need to consider them carefully.
Excellent. So you mentioned delivery at 37 weeks because she has no severe features, serial monitoring, oral antihypertensive. But intrapartum labor management would be the same. Would you give him magnesium sulfate?
Yes.
No seizures?
Yes.
She's not severe. If she had severity, then you would.
So if it's mild preeclampsia with no severe features, no need. If there are presence of severe feature, then we can give magnesium sulfate. But again, some physicians, they opt for magnesium sulfate even if the patient has mild preeclampsia. Now this patient, she presented with headaches and blurry vision. Examination shows 5 basilar theracles and 3 blood-splitting edema. Her blood pressure is 166/155. 115, and what's the appropriate management?
Delivery.
Stabilize.
Stabilize. Administer corticosteroids and plan for delivery.
Deliver.
Excellent. Deliver. So we deliver at which week?
34.
More than 34
Okay, so at least 34 weeks, so immediate stabilization, blood pressure control. We do continuous maternal and fetal monitoring, and immediate delivery if there are signs of mid-organ damage. Like with intrapartum, okay, what will you do?
Steroids
Excellent.
for 40 hours prior to delivery.
Magnesium sulfate.
Magnesium sulfate. For what?
Eclampsia.
For seizure. Like, important thing about magnesium sulfate, so we said it should be administered to cases of severe preeclampsia, and you need to watch out for signs of hypermagnesemia. Do you remember any other indication of obstetrics with magnesium sulfate?
Labor management?
Yeah, when? In which cases?
Premature.
So here for seizure prophylaxis for preeclampsia. Yeah, what did you mention?
It's used with dorsalis.
Yes.
Tocolytic?
No, obstetrics I'm talking.
Yeah, tocolytic.
Tocolytic? Well, not very indicated.
So it's given for preterm delivery. Why? For fetal neuroprotection and prevention of cerebral palsy. Do you remember that? So part of preterm delivery we give magnesium sulfate. Like contraindications, myasthenia gravis, completely contraindicated, and you use it with caution in renal insufficiency. Why?
Cannot be excreted.
Because it can lead to toxicity.
So magnesium is renally excreted. If not, will cause hypermagnesemia. And here you have this patient. She receiving magnesium sulfate for severe preeclampsia. She developed flushing, slow breathing, and absent deep tendon reflexes. So what's the immediate management?
Discontinue. Magnesium, replenish calcium.
Yes. So immediate cessation of magnesium first, and then you give IV calcium sulfate. Is there a way for preeclampsia prevention?
Yes. You can give aspirin for high risk women.
For high risk, yes. So in high risk, those who have preeclampsia, hypertension, diabetes, multiple gestation, very important. Any twin pregnancy, starting from 12 weeks, the mother should be taking aspirin. Moderate risk like obesity, advanced maternal age, like parenting, IVF conception. So indication of the patient has one high risk factor or two. For our patient in the case, she should have been taking aspirin. Okay, because she was nulliparous and she had advanced maternal age and obese. So she had 3 moderate risk factors. So prevention would be with low dose aspirin, initiated at 12 weeks, continued until delivery. Like this. Now moving on to the approach to the congenital anomalies. So usually it starts from before conception with parental carrier screening, so screening the parents, and it can be done as a part of the also the premarital screening. Then after conception we do the prenatal screening tests. Like what?
NIPT?
Excellent. Doctor, would you like to start?
Sure. So when you get a do the NIPT,
At 10 weeks?
in which trimester?
10 weeks?
10 weeks. For which group of patients? صوتي واضح ولا جلد المرض؟ جلد المرض. So which group of patients you need to do it?
High risk?
High risk. Who are the high risk?
Late maternal age?
Depend on what?
Maternal age?
Maternal age. What age?
More than 35.
35. Okay. What else?
Prior history of congenital abnormalities?
Family history. Okay. So the age group of 35 and above, it used to be the indication, but now the American College of Gynecology and Obstetrics, it's recommending it for all age groups. So any pregnant lady needs to do it. As you mentioned, it's in the 10th week of gestation. What is it exactly? What is an IPT? It is non-invasive prenatal testing. So what's the difference between this one and the invasive one?
They use just serum from the mother.
Yeah, so it's from the mom. We call it free fetal cells. And for what? What diagnostic purpose you do it? Why are you doing IPT?
Trisomy?
Yeah,
Non-disjunction?
so trisomy belongs to what anomalies?
Non-disjunction?
What is it?
Non-disjunction?
أنا شوية لا الصوت ولا سمع اليوم.
لا
معلش.
chromosomal
علي
non-disjunction.
صوتك.
Non-disjunction.
Non-disjunction, what is it here? Aneuploidies, okay. So it's basically numerical chromosomal abnormalities. So usually we cover the 3 chromosomal abnormalities. Which one?
Trisomy 21.
Trisomy 21,
18.
18,
13.
and 30, okay? So it's a very primitive test, but if you found it positive, what are you gonna do?
Confirmatory test.
You do what test?
Amniocentesis or CVS.
So amniocentesis and chorionic venous sampling is the procedure for taking the fetal DNA. To do what test?
Karyotyping.
Karyotyping, okay. What else? Do you have any other options? So karyotyping, if you are still suspecting numerical abnormalities. What else?
PCR.
PCR for what?
any genetic abnormalities?
Yeah, I mean, what is PCR?
Polymerase chain
You're
reaction.
putting yourself in danger now. Is PCR is a test. It's a method.
Yes.
It's a method for a test.
Yes.
Yeah.
What's the test?
In the slide, if you have other tests, حط it here. The one that has. Okay. Yeah. Do you know about FISH? Okay. So what's the difference between FISH and karyotype and the microarray?
Fish use probes
Uh-huh.
that bind specific DNA segments
Excellent.
on the chromosome.
Yeah.
They will fluoresce when that allele is positive, for instance.
Yeah. So basically, FISH means that you are looking for a very specific diagnosis, very specific defect in the chromosome. The difference between the FISH and the karyotype, that the karyotype is give you general impression about the number of the chromosomes and their location. So if there is any abnormal translocation, it will be detected by karyotype. But if you want to do something specific, you are looking for specific microdeletion or microduplication, you're going to do the FISH. So what about the chromosomal microarray? What's the difference? I mean, you have the sample now and you need to deal with it, right?
For the microarray, you're taking the sample and you're applying it onto the chip. Whereas fish, you take the probes and you apply it onto the sample.
Yeah. But the indication, why I need to do that test instead of the other one?
It's more of a screening.
I need everyone's participation. Guys, ما في marks. Just put your thoughts.
Fish is more specific than chromosome and microarray.
So it's not more specific. It's more comprehensive. So the difference that it's gonna give you the number, but it will also detect the micro deletion within the chromosome and the micro duplication. Okay? But one of the limitation of the array that it will not give you any balanced translocation. Okay? Sometimes we have balanced translocation that it will be detected by the karyotype, but you cannot get it in the chromosome and microarray. Why? Because we're looking here into the dosage of the DNA material in the chromosome. So if I have balanced translocation, the dosage is just A, okay? So it's gonna detect only the abnormal dosage, either deletion or duplication. Usually we do it for suspecting microdeletion and microduplication because the karyotype has limitation in the bases that it will cover. Okay? Right. So we mentioned about the chorionic villus sampling, the amniocentesis. You need to know the timing of each. What will be the risk of each?
Miscarriage.
Miscarriage. Yeah. What is the frequency of the miscarriage?
0.1.
20% nobody gonna do it.
0.1 in amniocentesis,
Yeah.
0.5 in chorionic villus.
Which is higher?
Chorionic villus.
Yes, because it's an yearly trimester, and you don't have that much DNA, like amniotic fluid. Okay. So when you're gonna do these tests? In which trimester?
First test.
Why?
To
Why you need to do it in the first trimester?
be able to terminate. Yeah.
So it's to make a clinical decision. Is it done for all pregnant ladies?
No.
So to whom we have to do it?
To anyone to which the screen is positive. I'm assuming.
So if your NIPT is positive, this is one scenario, okay? So the other scenario that if you have already a pregnant lady who has a previously affected child with chromosomal abnormalities. The other scenario, if you have a fetus with abnormal antenatal ultrasound. Is there any other test that you can do within that window in addition to this? What are they? If you are saying yes, please.
Nuchal translucency. Nuchal translucency.
This is by ultrasound.
Yeah.
This is just like one of the signs, and it's also non-specific.
Yeah.
Okay, but are there any other tests that you need to do?
Oh, quad test, triple test.
What?
Quad test, triple test.
Okay, those are screening tests. The people who attended my lecture. So the third scenario, if you have a lady who has a previously affected child with a genetic disease that is due to single gene mutation, would it be covered by these tests? No. Why?
Because they're not designed.
This is the indication of PCR to do targeted mutation analysis. Okay? Because we're talking here about a very small genetic defect within the chromosome. And it's not covered by these tests. So the fourth test is the targeted mutation analysis. But you need to have a confirmed case. So you can rely the test on that one. Are there any other tests that you can do antenatally for congenital anomalies or genetic defects? البنات أحسن منكم, sorry to say this. So you have to just participate. For you guys. ولا بصاري الأسئلة. Did you hear about whole genome sequence, whole exome?
Yeah.
When are we gonna do these tests?
Sequence.
Yeah.
Maybe if our tests fail to detect any mutation, then we can go whole genome sequencing.
Why they failed? So just there is a simple rule. You don't do these invasive tests unless you have a very high risk pregnancy. Okay? And this is indicated by either abnormal screening test or abnormal ultrasound that is indicate complex anomalies. So even if I don't have a diagnosis on that family, and I have a very complex anomalies in the ultrasound, I need to do advanced genetic testing just for diagnostic purpose. So whole exome or whole genome sequence can help me in that. I can even do it beyond the 21st week of pregnancy, just for diagnostic purpose. Why I need to do these tests in the first trimester? Because as you said, as your colleague said, that you need to take an action. And the action usually should be done before 21 weeks of pregnancy. And why is that? ليش حطوا لنا 21 weeks?
Because of legal,
Why shouldn't it interfere after 21 weeks, even if the fetus is affected?
legal issues.
What does it mean? Why legal?
Yeah, insolvent is at 120 days.
Exactly. So you cannot interfere after insolvent, okay? Even if the fetus is affected, you have to keep the pregnancy continue unless it's affecting
The mother.
the mother, okay? Just quick highlight about the intervention that we do. So one of the intervention that we do is the abortion. What's the rule for the abortion? When we need to abort? And remember, it's very optional. Sometimes we do the genetics testing, the family elected to continue the pregnancy. Yeah. Okay, maternal causes, fatal danger. Okay, what else?
Any
Yeah, what's the problem with the trizomes? Yeah, if you get an affected baby with trizomes, what's the problem with that?
severe disability.
لا إذا كل شيء يكلف على الأهل دي report everyone kids يكلف على الأهل. What type of defect they have?
Intellectual defect.
Intellectual. So the general rule, anything that affect the cognition or the individual life, which means that even if they don't have cognitive anomalies, but they have risk for severe metabolic crisis that is affect their life, we go to our religious regulatory, which is هيئة الإفتاء. So they allow these two conditions. So we have a list for the disorders that is allowed for termination. Okay? So it's completely governed by our religious regulatory people. Okay? So we're not allowing abortion to all the disorders. We have more than 25,000 disorders. So we're not allowed to do that for every single disorder. There are congenital disorders that it only affect the skin, okay? Only affect the vision. They're not allowed to abort this disorder. So the rule that you interfere if it's affecting the cognition or their own life, like it's risking their life, okay?
Dr. Kia, may I ask something?
Yeah, sure.
If the offspring
Yeah.
is diagnosed with thalassemia major,
Yes.
is abortion allowed?
Yeah. Thalassemia, sickle cell anemia is included. Yeah. Fortunately, these two disorders are included in premarital cystic.
Yes.
Okay? So usually we got the usually it's already prevented. But sometimes if the family elected to continue the marriage, we stuck with those kids and we get surprised that we got pregnant ladies with affected fetus with sickle cell or thalassemia. So in that case, they are even elected to keep the pregnancy or abort the affected fetus. All the disorders that I mentioned in the newborn screen, it's open for termination. Okay? Any questions? Okay. Good?
Thank
Yeah.
you.
Thank you all.
So, do you have anything else to ask or to add or to comment about your PBL, especially about PBL phase, or about the blog in general?
No, I just don't understand what's the rationale of using magnesium sulfate.
Sorry?
What's the rationale behind using magnesium sulfate? I do not understand.
I am not an expert.
Me too.
So do you know the mechanism of action for using something?
No.
Membrane stabilization. Membrane.
Okay.
Thank you so much.
Yeah. Okay. Sure.
So mechanism of action.
Membrane stabilization.
It's excellent by,
Hyperpolarization.
which means
No more seizures.
it's
Prophylaxis.
excellent. So basically, it acts on the calcium channel blockers. Calcium channel. So they block the calcium channels. This would raise the seizure threshold. Okay.
And for using it for other than seizures, what else can you use it for?
TBP.
Fetal neuroprotection, as I mentioned, for cerebral palsy.
بس هيك.
Yes.
Oh.
But there are other indications for حتى they use it for asthma, do you know?
I think I've heard that.
Asthma exacerbation, you can use magnesium as well. But has صراحة different uses depending on the يعني سبحان الله. It works the native fetal neuroprotection. It also is, I think, the same mechanism as the bradyclampsia, but can also be used in asthma. Used for which condition as well?
Which side's this one?
which is caused by
polymorphic ventricular tachycardia,
or
antibiotics, antipsychotic,
excellent. Which electrolyte abnormality?
hype.
Hyperkalemia. Yes. So it's used to treat hyperkalemia.
Because it's like
Now, just to conclude, do you have any questions regarding the other objectives? So, we discussed the congenital anomalies. Yeah, guys, please note that the management should be multidisciplinary care for any congenital anomalies. Now, the doctor estimates the screening program. We are the screening. Important to know which disorders are involved. Like, what's this?
That is an equation.
Excellent. Yes. Seen in what?
trisomy 13.
No. This is. What's the?
Prominent epicampal fold. No?
No substance.
What can you notice at eyes?
Like of the mesothelioma.
So the eyes and the nose.
Very close.
Slots into fold.
They're very small.
Yeah.
This is we call it microphthalmic. And the nose is broad. We call it bulbous nose. Now this is
Cleft lip.
lip double palate and deformed ears.
Omphalocele.
Phallocele. Excellent. What's this?
What is that?
Capillary hemangioma. So all of these are features of which
Patal.
Patal. Like what's this?
Single palm artery. Pyloric stenosis. Yeah.
Duodenal atresia. Excellent.
Orange gum.
What do you call it? Sample gap.
These are the epicampal folds.
Yeah, I see every kind of fold. Excellent. This is the eye. What do you call these? Brush beam spots. So these are seen where?
Down.
Down. Like,
Low set ears.
excellent. And
Prominent occiput.
yes, prominent occiput. Excellent. Clenched fist and
Overlying fingers.
rocker body. Now what's the CT scan show?
Annular pancreas. No, sorry, annular kidney. Horseshoe kidney.
Excellent. Yes, horseshoe kidney. Like, what is this expression?
Non-rotation.
Or development of the horn.
Sorry. Stage 4 hernia.
Hernia away.
Diaphragmatic hernia.
Excellent. Yes,
Stage 4 hernia.
diaphragmatic hernia. So this would be an honorary syndrome trisomy 18. So just briefly on psychiatric disorders, so we do screening codes, the clinical assessment of suicide risk. You need to exclude medical causes, but assess for comorbid conditions, like anxiety, PTSD, substance use disorder. Like the classification of mood disorders, 3.
Yeah, there is the blue, baby blue, which is less than 2 weeks.
Excellent.
There is the depression, which is more than 2 weeks. And there is the psychosis.
Excellent. Both parts blues, the most important thing about it is that the features, the mild depression and irritability, they do not appear in the ability to care for the baby. Then for the depression, the same as clinical depression, same criteria, but only with very Barton onset. In the psychosis, they have psychotic features, and the most important risk factor for psychosis is what? Bipolar. Personal history of bipolar. Like diagnostic criteria, very important to know the symptom onset, up to 12 months. Previously, they used to say up to 4 weeks, but now up to 12 months. Same criteria as the depression. It has to impair the social, occupational, other areas of functioning, and should not be introduced with other medical problems. Management?
SSRI.
Excellent, yes.
So I need suicidal thoughts.
Excellent.
CBT.
CBT and IBT. So first line would be psychotherapy, CBT and IBT and SSRIs. If severe, what do we do?
That's so well.
Hospital.
Hospitalized, excellent.
Haloperidol.
Excellent, but this is for antipsychotics. But if there's psychosis, now very important new drug that you need to do is zuranolone and brexanolone. These are really important. These
What
are
are
GABA
they?
enhancers, and they're new FDA approved for only postpartum depression. Right? Their mechanism of action that they enhance the GABA, so they improve the depressive symptoms. And now, if the patient is doesn't improve or they have severe suicidality, then we do
Institutionalization? Like, admit them? Admit them?
Antipsychotics.
no. Electroconvulsive therapy.
And it works fast.
Mm. It works really fast. It reverses the symptoms immediately. But this is reserved yani, for cases of severe suicidality, psychosis. Like, we'll end with a question. Can someone answer this?
Want me to read it?
Yeah, these.
27-year-old woman with a beta 1 pair of 0 comes to the office for initial prenatal visit. Patient has no chronic conditions and has had no surgeries. She takes a daily prenatal vitamin. Vital signs are normal. Ultrasound shows 2 intrauterine fetal poles measuring 14 weeks gestation with heart rates of 150 135. Which of the following is the best next step in the management of this patient? It's not.
Why?
B?
No.
D?
Why are you?
D or B? Why?
Why are you giving her anything?
I think
Why
maybe-
is indicated?
maybe it's the institution.
No, this is the heart rate of the baby.
It's like a double. Is it a risk factor for the early delivery if it's twins?
Is it a risk factor for preeclampsia?
So we can.
Possibly.
So their ultrasound shows 2 intrauterine fetal poles, yani multiple gestation. So we give. Okay. Any questions?
That's exactly what.
Yeah.